Welcome to Physicians Keepers. Each episode features honest conversations with physicians, sharing moments that shaped them, challenged them, or taught them something worth passing on. These stories come from every corner of a physician's life: the clinic, OR, family, finances, mental health, leadership, and personal growth. If a story can help another doctor feel seen or strengthened, it belongs here. It's about honesty, courage, and community true storytelling. If you are looking for connection or a reminder that you are not alone in navigating this profession, you are in the right place. Hello and welcome to another episode of Physicians Keepers. I'm really excited for this episode today, and I have with me Dr. Rodrick Stewart. And I'm so excited that he volunteered to be a guest on today's episode of Physicians Keepers. Could you just briefly introduce yourself, Dr. Rodrick?
Sure. Yes, my name is Rodrick Stewart, DO. I am a family medicine physician. I work just outside of Atlanta. I finished my family medicine residency training at Morehouse School of Medicine in 2020. Before that, I went to the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. And right out of residency, I started working in primary care and HIV, and now I pretty much do bread and butter primary care, like I said, right outside of Atlanta. I'm very excited to be here, and I think it's going to be a really good conversation.
Absolutely. And so from one primary care to another, thank you for holding down the fort over there. So we have a very interesting conversation to talk about today. And I'm really interested to hear your take on this because I mean it's something vital for primary care, definitely because of the conversations, we're the talking people, right? I think we in psychiatry we hold when it comes to the what's the word? The candle with that,
Mhm.
the torch in the talking aspect. If you don't want to talk to patients, you're not a talking type. Primary care is definitely not your dig. Like
Absolutely not.
you can't avoid the conversations about the grandkids, about the trips, about the what you would call mundane things, right? That patients come that are totally not related to the visit, but are, they're important to the patient. And
Absolutely.
you're bringing in a conversation where we talk about, love ethics, with our patients. So when you say that, what do you actually mean by having like a love ethic with your patient?
Great, good question. So, I've been on a really big bell hooks kick. Started with reading. I think my first book that I read by her was The Will to Change, talking about masculinity and
Yeah,
patriarchy and how things about how we see masculinity need to change for, I guess, the world to kind of be a better place.
yeah,
So that opened up the door to some other books that I've read. And I recently finished, probably for the third time, the book All About Love. And for the first time, I actually had someone lay out in written word what a good working definition of love as a verb and not just as some sort of nebulous feeling.
yeah,
In it, I'm going to have to actually read from it. So in it,
absolutely.
Hooks talks about these basically like six core components that she talks about in the book and when it comes to love. It's care, which is care is the thing that most people associate as love. I care for you, therefore I love you. But she goes further to talk about commitment, knowledge, or continually looking for understanding of the person that you are loving, responsibility for their well-being or their spiritual growth, respect of that person, trust within that person, and honest and open communication. And I believe a lot of these things have been missing from medicine. When it comes to primary care, we like to talk about doctor-patient relationships as the most important part. And
Yeah.
to have a doctor-patient relationship that's robust and beneficial on both ends, you need lots of those components. So you need to care about your patients. You need to trust that your patients are telling you the truth and being forthcoming with information. They also
Yeah.
need to trust you and that the information that they divulge to you, that they're not going to be judged about it. They're not going to have some sort of negative outcomes because there's a lot of distrust within the medical system. I know we learn about, especially when it comes to our Black patients, when we talk about distrust of the medical system, there's a long
Yeah.
history of mistreatment from for the pursuit of science for our people. So trust is very important. Respect. A lot of our patients don't feel respected. They feel as if they're rushed into the visit. They get 2 to 3 minutes with us and then they're pushed out the door with some pills. And a lot of times they don't feel as if their goals are kept to the forefront. They don't feel as if they are being listened to when it comes to medications, lifestyle choices, you name it. And then, of course, the knowledge. When we talk about those mundane things, that small talk, those are the important things for me because the medicine is the mundane. There's only so many ways you can diagnose hypertension, high cholesterol, type 2 diabetes. There's only so many ways that you can treat these things also. So I tell my patients, the medicine, like that's the easy part. It's understanding who you are from a whole person perspective because it's not just that you show up with your blood pressure high. It's you show up and you're not sleeping at night because you're very anxious about what's going on in the world. Your job is the thing that's bothering you the most. You have bills that are due. You have children that are maybe not doing the best in school, or you're raising children in a world you're not too sure about. There are a lot of other stressors that impact your overall health. So if you're not sleeping well, if you're not eating well, if you're not finding time to exercise, if you're not finding good stress management techniques, those all impact your overall health. And a lot of times we as physicians, we don't get that information from our patients because of the fact that we're on that hamster wheel. We're on that clock and we're thinking about the next patient instead of just sitting there and being present with the current patient. Um, I know that as I've been trained as a physician, we train in efficiency and moving to the next patient and going on and learning how to ask specific questions to get specific information. One day as an attending, because that's when you actually learn medicine is when you're alone and
Yeah.
there's no one there to save you.
Supervise. Yeah.
Right. As an attending, I just decided one day I was going to throw it all out the window and I was just going to be present with my patients. And I was going to make the most important part of my visit connection with them. And over the years, I've noticed that I get a lot more information a lot more pertinent information out of my patients. They actually stick to their treatment plans because they're treatment plans that we make together. They're happier with their care. They actually come to their visits. A lot of our tougher patients, specifically male patients and specifically Black male patients, who I hear a lot of talk about in terms of not being aware of their health status, not taking medications, not showing up to the doctor. Those are some of my best visits. Like they show up, they're motivated to better their health. A lot of times they don't want to take medications, so I challenge them to do things that we tell them all the time in terms of lifestyle changes. I challenge them to do those things, and they respond very well to it, specifically because they see that I have buy-in to their health.
Yeah.
So I've taken this and I've just ran with the fact that if you approach everything in your life with a love ethic from this perspective of, am I hitting these core principles, then you'll see that so many things in your life become, I guess, quote unquote, easier.
Yeah. Well, that is awesome, because like you said, everything that you mentioned was part of the initial reason that we were drawn to medicine, right? That we said we're gonna, really help these folks. And, somewhere along the line, right, because we live in, a corporate world, the business part, sometimes the business side takes over that really wanting to help and dig down deep. But I mean, so let me just give an example. I'm in a setting where, I mean, I
Mhm.
have 15-minute time slots with every patient,
Right.
30 minutes if you're a new patient. And then how realistic is it though to establish that connection
Mm.
with patients in that time slot? Like, because sometimes you really want to, but then you're looking at the schedule and like, oh my God, they're still putting patients on the schedule.
Right.
Like, how do I be present, completely in knowing that I have such limited time with this individual?
Hmm. Yes, it's a challenge, and it's always going to be a challenge as long as we accept what we're given. It's like just my in your face answer.
Yeah,
I work in corporate medicine myself.
yeah,
A big hospital system up here, and they have their mandates. They want me to see a certain number of patients on a daily basis. They want me to log a
yeah,
certain number of RVUs.
yeah.
For those who are listening who don't know what RVUs are, those are relative value units, which are basically the currency by which our time
Measured.
given
Yeah,
is measured against, is a given
yeah.
value. So,
How we get paid.
right. I feel that crunch as well. But I'm adamant about, in terms of my schedule, I'm adamant about what types of patients that I have, how much time I have with them, because I'm in the same boat. My physicals are 30 minutes. My average patients are 15 minutes for follow-ups and 30 minutes for new patients, so very similar. I spend a lot of time in the very first visit. So each actual follow up, once we get them stable, like they can be pretty efficient, but I don't let it stop me. In fact, with some of the way that I code, once I know that a patient is going over a certain amount of time, I just switch to time coding. So I'm not afraid to code a 99215 on any patient who goes over 40 minutes, which a lot of them do. So I'll log a few 1.5s in the course of my day. I mostly log 99214s for my follow-up visits too. So that kind of balances out the demand for RVUs because of those are higher acuity codes that I use.
Yeah.
Um, but yeah, at the end of the day, the way that I structure my practice, the way I follow up with my patients, I do a lot of upfront um, communication with them so that I spend less time in the portal afterwards typing to them. We have less callbacks to the office because patients are confused because we spend a lot of time educating them initially. So compared to my colleagues in the office, I don't have nearly as many messages waiting for me. I don't have many calls. My inbox stays empty. Like by every Friday, my inbox is zero. So I have colleagues who like they have messages and notes to catch up on and numbering in the hundreds. Those red numbers bother me. So I make sure that I am always cleared out every Friday. So every now and then it means staying after no more than an extra half hour
Yeah.
because I usually have to pick up my kids from the after school program and past 6 o'clock. That's when they start to charge you more money. So I make sure that I spend all the time that's necessary, and I routinely walk into patient rooms late, but my usual message to them is, I'm running behind because I was present with another patient. I promise you that I will give you all the time and attention that you need as well. However long it takes me to complete this visit is how long it takes me. I'll give you as much time as you need. And very rarely do the patients complain about the amount of time that it takes because they know that they're getting as much attention as my other patients do.
That's awesome. That's awesome. Now, possible? Can you be a great doctor without those connections? Like, do you think that's possible?
Ooh, a great doctor without those connections. Because it really depends on what you define as a great doctor. I do like I we all know a lot of doctors who have encyclopedic knowledge. They know everything about medicine. They can tell you specifically how every medication works biochemically, all of the side effects. They can tell you everything about medicine. But when it comes to connecting with patients, they don't have the greatest survey results. So there's that missing. And one of the I've lived by several sayings. One of the sayings I live by is the best treatment or the best medication is the one that the patient will take. And if you know how the medication works, you know it's the best for them, but you don't spend that time educating the patient and you don't connect with that patient to say, hey, you may get some side effects, but maybe they'll go away in a couple of days. Or if you do get enough side effects that they're bothersome to you for your quality of life, you can contact me and we will change the medication. They may get a side effect day 2, stop the medication entirely, and then never see you again. I've had that happen with several patients. They come to me for side effects of a medication that was given to them by a specialist. And I asked them, why didn't you go back to the specialist about this if the medication they gave you gave the side effect? Always they say, oh, I stopped the medication. I don't like that guy or I don't like that woman. And I'm just coming back here because, I wasn't listened to. They just gave me medication. It was 30 seconds. And now we're here, we're back to square one, and the problem still isn't solved. So even though the medication may have been the right one, if they had issues with it or they've had issues with you, then there's going to be a disconnect between your abilities and the belief in your abilities by your patients.
I think so. What you mentioned, like I said, is a very common thing with primary care. It's like, okay, you get to that point where you send the patient out, you refer them to a specialist for something because you're like, okay, I'm at my wit's end with this. I think I need to send it someone. And then they have one visit with that specialist, and then they're coming back to you for the same thing that you send them out for. And then when you're asking them, so what happened? Oh, well, they didn't touch me. Or, I hear that's like, I said I was coming in with a stomach pain, but then he just, he said, we do this, this, and this, and this. And it's like, you know, and they sometimes they did the test, but there was no open-ended conversation with them to say, hey, if this doesn't work, maybe we'll try this, or maybe we'll go ahead and do this. These are the options, or things like that. So they feel like it was just that one and done, and then they're back to you saying, "Hey, help me for the same problem that I just sent you out." You know,
Exactly.
and I guess as primary care, like I said, that's it's good for patients to feel like they can actually come back to you and say, "Hey, maybe that was not the right person for me, and I still think you're the right one that can help me fix this."
Mhm.
And so so I totally get what you're saying with that. Now, I wanted to ask, are there any specific phrases, habits, or mindset shifts that you recommend that physicians adopt? Like, is there anything you say, like when you walk into a room, that makes patient feel like, oh, this doctor, really cares for me, or I can be myself and not be judged by this doctor?
Mhm. Um, I would have to say never miss an opportunity during the history taking portion of the visit. I know, like when I was a student, when I was a resident, just taking the general history of a patient, the things that aren't necessarily related to the visit, but are still important for some people, that used to annoy me. Um, but I've found that even though there's information in the history that my medical assistant has already asked or is already in front of me, it gives me a chance to actually connect with the patient. So whenever I have a new patient come in, the first thing I ask them is how did they find out about our office? So that gives us a moment to maybe connect on. Maybe it was a word of mouth referral that brought them in. Maybe it was just the insurance company said I was one of the people in the area that they will pay them, they'll pay to see. But it sets the stage for us to have a conversation as opposed to me just, interrogating them about what's wrong. And then we go into their social history. So we ask about smoking, we ask about alcohol use, ask about drug use, not specifically because it hasn't been done, because I see the answers right in front of me, but also These are the behaviors that, although for the most part we do want these behaviors to change if they're problem behaviors, but these are also the behaviors where your vulnerabilities lie. Some people, they lean towards these vices because of the vulnerabilities in their life. Maybe there are some things that they don't want to talk about, or that they can't usually do unless they're engaging in these vices. So when we talk about smoking, when we talk about drinking specifically, how often are you drinking? If it leans towards a problem, then the conversation steers towards things like, well, why do you feel the need to drink so much? Why do you feel the need to wake up in the morning and have drinks? Is there something in your life that you may be, hiding from? Then we talk about recreational drug use. This time of the world, there's a lot more recreational marijuana use, and there are also some other drugs out there that people are using. A lot of synthetic drugs, and they're the reasons that people are using the drugs are also different. At one point in time, it was just a party. Now, we have people who will wake up and smoke a joint just to get through the day because of how stressful their life is. And that opens up the possibility of talking to them even more about that. Then there's the part of the PHQ2, which is part of our screening requirements in primary care, is to
Yeah.
at least once a year see if your patients are depressed. So I see the score that my medical assistant already calculates before I walk in. If it's more than 5, then we have a conversation. If it's really high, one of my favorite sayings is, "Oh, you scored really high on this test, and this is not the test you want to have a high score on. Tell me about your mood. What's been going on?" And I do it in more of a conversational tone. And then the one that really flips the switch on connection is really the sexual history, to be honest. So few physicians will talk about sex with their patients. And you wouldn't believe how many 40, 50, 60-year olds I talk to that say, "This is the first time I've ever talked to my physician about sex." And it's not just, are you having sex? It's, are you currently sexually active? Are you sexually active with men, women, everybody in between? So making a non-judgmental approach to their sexual activities, because some people are pansexual. They engage in sexual intercourse with a lot of different people. And then if they're, depending on their question or the answer to the question, then we can talk about other things. Are we having safe practices? Are we mixing substances with our sexual practices? Is there a need to talk about PrEP? We can open up the conversation to a lot of different things, but my entire intention is to make sure that we keep it conversational. I try not to use any like overly scientific language. I try to use a very common, wording, vernacular, and just make it seem as if, I'm not bothered by the things I'm asking you, so you shouldn't be bothered either. And it's almost palpable, the tone shift that you can see in people, because
Yeah.
they're always sitting up when they're worried about what's going on. This new doctor, I don't want to say the wrong thing, but then when they have a doctor in front of them who's using the same terminology that they're using, not batting an eye about it. I'm not shying away from any of the information. I'm not apologizing for asking the question. I'm asking directly, and I'm telling them that there is an important reason for me to ask this question, because I want to see who they are from a whole person perspective. And giving them the information that their mental health, their spiritual health, their physical health, their sexual health, they're all play a big part of the whole. So as soon as those questions come out, the people, they relax, they'll start telling me information that I didn't even ask for most of the time. And then the questions come, like the real questions come, the real information that they want to know. So I would say that taking that time to have a nice, robust conversation is very important, because, once you establish who the people are, who the patient is as a person, you make that connection, you empathize with them, and let them know that, you are here for them, most importantly. then whatever information that they came in to, or whatever issue they came in to solve, that becomes easy to find. It's most of the time when I have a new patient, I already have the labs keyed in. You know, I already know what I'm going to do based on either their complaint or the fact that they're coming in for a new patient physical. Like all that stuff is either I'll either have all of the pieces in place, or I'm only missing one or two pieces of information to really give me a good lead on where I need to go. So the rest of the visit is getting to know them as a person.
That's amazing. Pretty much the way you broke it down. I remember a project I did in residency where we're talking about, STD screening,
Hmm.
and the slogan we came up with was actually a clam was our mascot, and it was like, "Don't clam up, talk to your doctor about chlamydia screening." But But yes, that's like I said, that's one aspect, of, patients that they feel like they, you know, should keep away from
Hmm.
their doctor, and then a lot of them are not comfortable sharing that. And based on your approach, I can totally see how even if, perchance you were not, after all these conversations, you were not able to get like into like the fine details of the drugs and the medicine, like if you say, we did cover a lot of ground today, but I would like to see you back in 2 weeks so that we
Hmm.
can dig deeper. You would then see that patients would be more receptive to actually
Absolutely.
come back and say, okay, not a doctor's visit that I really didn't want to come to. But yeah, 2 weeks, if we can come back in 2 weeks and actually like break this down, and we can have these type of conversation again, where I feel like you don't see me as just a number that you
Hmm.
checked off your list, but actually like as an actual person. Then like I said, because the whole idea is having better outcomes for patients, right?
Hmm.
That's why we practice medicine, not just to get paid, but to have not just to see them, but also for the patient to have a better outcome. And
Right.
that looks different for every patient, right? Some patients find they get the medications for the blood pressure and all that, but that's not their desired
Hmm.
outcome, and so hearing, okay, what are your expectations? Those questions that we avoid, or the one that, we kind of have to grow into is there anything else?
My favorite question.
Is there anything else that I can do for you in this visit? But I think having a good mentor in that aspect, especially in training, does help.
Hmm.
And one of the things that, one of the our mentors in residency taught us was like, you can have your own agenda. Patients have their own agenda whenever they come to a visit. If
Hmm.
those two do not line up, you, in your mind, you may have delivered what you thought was the best medical advice to the patient, giving them the best prescription. But if that did not line up with their agenda for their visit, they would leave there feeling like that was this is not happening anymore. Like, I need to find somebody else. And
Right.
so he always had us, have that question, say, what how can I help you today? And sometimes, as a physician, I've gotten mixed responses to that because I walk in and I'm like, how can I help you? It's like, didn't you look at my chart?
Well,
Like,
yes.
but you're my doctor, you should know. Why? I'm like, well, I get that, but I do have a list that I have here, but I wanted to know what
Hmm.
did you coming today
Right.
expecting from today's visit so that we can both leave here, knowing that our agendas, we came to the middle with
Hmm.
our agenda. So, but the way you broke it down in terms of, when you talk about the history and getting it step by step, that I said, I can totally see how patients will like, I need to come back because I totally felt heard. I felt visible when I saw my doctor. So another question to ask you. What is the fastest way that a doctor can lose a patient's trust?
Ooh, let's see. The fastest way. I think the fastest way you can lose patient trust is, I think we've hit on it, is the not listening to them when it comes to their goals. If they say they don't want to be on medication, and the first thing you do is offer them up two medications without rationale, then that's where you lose them. The patient, they want to be heard. They want to know that they're a part of their own treatment plan, and they're not just being pushed on. Like they already think that we're getting money from all these different things, from prescribing meds to the vaccines to everything. They think that we're in bed with all of these
Big
different
pharma.
entities that I wish were paying me, that are absolutely not paying me a single dime. But yeah, you want to make sure that you're listening to the patients. I've had, several of them come in, they're on like three different medications. Like I'm a fan of consolidation. So if you're on a couple of different blood pressure medicines, I'm a fan of multi-drug
And we
regimens.
max out yeah.
Yeah, so combo pills, I'm a fan of that. I say, well, you're on three different meds. Let's put it all into one pill. Let's change that up. Or one of my other favorite sayings to the patients when they come in and they tell me from the very beginning, I don't want to be on medications. I know I haven't seen a doctor in 10 years. My blood pressure is 200 over, 150 at the moment or something like that. I've had patients come in who have really high blood pressure. They don't want to be on pills. And I tell them, okay, at this point in time, your blood pressure or whatever issue we're talking about, your blood sugar, your cholesterol, something is too high for me to be able to send you home without some sort of medical intervention. However, this can be temporary. I don't like prescribing medication as much as you don't like taking it because it just makes more work for me. That means I have to keep track of your medications. I have to keep track of certain labs. I have to see you more often. And it doesn't mean I get paid more for the same work. So I let them know straight up, I don't even like prescribing medications. If it were up to me, all my patients they would see me once a year. They would take care of everything from a lifestyle perspective. So I tell them there is a way that you could get off of medication. There's possibly, because sometimes it's genetic, sometimes it's entirely behavior, sometimes it's a combination of the things. I tell them that medication could be temporary. Now, the temporary depends entirely on you. This could be a 3 month temporary, or it could be for the rest of your life. But one way or the other, you're going to stop taking the medication. So you're either going to stop taking it when your behavior catches up, or the day you expire when you just stop taking medications entirely. But it's up to you what temporary means. And I put the ball in their court. I let them know that I will be glad to de-escalate these medications. I will take them off and stop them as soon as I see that what you're doing at home is reflected in changes in your lab values and in your vital numbers. That's it.
That's awesome. One of the things I frequently tell patients, and this was something that I learned from especially lifestyle medicine was that I'm not the driver of this vehicle when it comes to your life. Like I'm just in the passenger side. Like I'm giving you directions. Like I'm not the one saying, yes, you got to do this. Yeah, it's like I just say, hey, I think it's better return this way. But then if
Right.
you crash the vehicle, it's totally on you, right? Because I'm just in the passenger strapped in, but you're the one championing this desire to be healthy.
Mm-hmm.
And so it puts it on them because that's really what it's supposed to be. Like patients have to take responsibility in certain things and not feel like you just give me a pill and you fix me. That's not that's
Mm-hmm.
not always how this works. And so like I said, that's pretty reflective and impactful for physicians to hear. Now, we know that burnout is a thing, right?
Mm-hmm.
It's a big thing with us.
Very big.
How does a burnout physician show up? Is it possible to be burnt out and then still enter a room and be present and feel like you're connected to this or develop those connections? Like, do those two things, can it work?
Mm-hmm. Uh, Personally, this is only my opinion. I think those two things are mutually exclusive. I don't think that you can be burnt out from the perspective that you are stretched thin at work, like you're constantly stressed, you are not thinking straight. The just the sheer amount of work that you have to do, whether it's emails, portal messages, labs, number of patients, like the amount of stuff you have to do in a day. you never have enough hours because you're constantly um, being pushed by an invisible force. Like there's that clock on the wall that's constantly telling you that you're behind. So if you're at the stage where you're burnt out, then I think it's impossible for you to sit down and be connected because you have to be present. And those people who are burnt out, they're never in the room. They're always in the next three rooms. They're always in their office typing up the letter of medical necessity for the prior authorization. They're always in three or four different places at the same time. And that's what leads to burnout. The fact that you have so much to do and so little time to do it that you can't have that connection. You have to be present. Presence requires your mind to be in your body in this very moment in time. Like you have to be in this moment in time. You can't be in the future. You can't be in the past. You have to be in the present and you have to be in front of the person in front of you. So I don't think that the people who are burnt out can connect. However, you can get back to the point of getting connection by undoing that burnout, by letting go of some of the things that you can't control, by hopefully taking some things off your plate. If if you're working for an organization, hopefully they're implementing something to decrease the workload that you have, and also hopefully you're advocating for yourself, um, because we are the commodity. Our time is really what's the most precious thing available to us. And I I'm one of the docs who early on when I started my attending career, I am not hitching my wagon to any specific place. If I find that you guys are not listening to me when I tell you I don't want to see 20x patients and I don't want to have to work several hours after I leave the office and go home. If I'm home, I'm home. So if I start to see more and more work piling up as I'm getting home and I'm getting more and more patients put on me as I'm telling you guys that this is too many patients, if you guys don't listen to me, then I am all for leaving. I will leave a place very quickly. I have no, I guess, yeah, I'm not loyal. And
Gotcha.
I know my worth and I know that I'm not loyal to any place that I work for. And I will let them know that if you start to push more work on me, even though I clearly tell you where the boundaries of my comfort are for the amount of work that I can do, if that exceeds it and you guys continue to overstep the bounds, you become habitual line steppers, then you will see me chuck the deuces and I will be moving on because we're physicians. There was a
Yeah.
shortage before COVID. Like there was a physician shortage before COVID, especially in primary care. After COVID, it got worse. So there is no shortage of jobs available out there for us. I understand that there may be some non-compete clauses out there, which may or may not be a thing because of it was the FCC ruling a couple of years ago, kind of made them null and void, but that's still in limbo.
Yeah.
But I read my contracts. I make sure I read every word of my contracts, and I know where my wiggle room is. So I would, recommend every potentially burnt out physician make sure that they read their contracts, know what's in them, know, what your out is. Like I always know what my out is, just in case that I tell you, what my needs are and what my desires are for growth within your company. We find that we're incompatible, then I have no problem saying bye.
Thank you so much for that word for, physicians, because like I said, because of the workload, the pressure, the um everything else attached to just seeing patients, right? Because that's what we
Mm-hmm.
thought we're just gonna do. Like, I'm just gonna see a patient, but that's this
That's just the beginning.
that's that's just the being, like you said, there's the prioritizations, there's the, patient satisfaction score. There's so many other metrics that you have to meet up with. And it's
Mm-hmm.
not just one and done. But, a couple of things I think I'm glad about, I'm not like my company doesn't have that yet, but I hear that AI coming, like AI scribes are making it a whole lot easier. Like being present in the room without having to worry about the dictation and all that. So, hopefully once that's a big thing, I think that would definitely help a lot of physicians regarding burnout. So we're excited about that part of AI coming in to help us as doctors. Now, this may sound like a weird question, but is there, have you ever come across that patient that quote unquote is unlovable or does not want to receive the love that you are giving?
Oh man. Yes, I've come across that patient several times. There are some patients who I will get who will hear about me and they feel that they just have to come over because the person who recommended them has, whatever positive experience it is. And you hear about that patient and how they're a problem to other physicians and how like no one likes them around. One patient in particular, I remember her because I think it was my first attending job. I'd been there maybe about 4 months, and the other primary care doc in the building, he was getting ready to leave. So when they hired me, he was getting ready to leave and go out west where he was from. So it was pretty soon that I was going to be the only primary care doctor in the building as they were trying to hire another one on. They weren't going to just leave me alone, but it was just me. So I inherited his patients. And of course, I inherited his problem patients because they had to be seen more often. They couldn't wait until another physician comes. One in particular, I remember because she was a pretty sad case. She had stage 4 breast cancer that was metastatic to the
Mhm.
bone. So her breast cancer had spread to several of her bones, and she was in a lot of chronic pain. So between the oncologist, her pain, well, at the time she didn't have a pain doctor. So between her oncologist and our office, she was on high doses of pain medication, and she had a few different anti-cancer medications as well. So the first day that I saw this woman, it was I will never forget it. Mind you, she's African American, so she's black. I walk into the room and she says to me, I told them I don't want a black doctor because black doctors are stupid. I want a white doctor. I want my white doctor. I want him back, but they told me he's leaving. So I guess I have
Oh,
to have
Lordy.
you. I was hoping that she would hate me enough to where she would request to leave because, like, the entire time we were in that office, she would tell me just about how stupid black doctors were, in her opinion.
Wow.
And by the end of the visit, somehow this woman went from hating all black doctors to hating most black doctors except for me. So I was like, I don't know what I did to keep you around, but yeah, until I left that office, she would always come in. She used to bring me. She would go to the farmers market. She would bring me oranges. She would bring me grapes and mangoes. She would just bring me bags full of fruit, and she loved me. She loved me like a grandson. Somehow she found it in her heart to love me. But every other black doctor she was completely against seeing. And I've had several patients like her in the, what is it, 2025? Yeah, in the 5 years now since I've been attending, I've had several patients like her that I thought for sure by the end of the visit they would request somebody else. But no, they kept showing up as my patients. And eventually, with some of them, we got through that rough exterior. We got through the trauma because a lot of it is due to trauma that they have had pushed upon them, either through
Yeah.
the system itself, through close family, but there's always some trauma that is lying there deep, and a lot of it has to do with maybe they were a caregiver for a different family member, or they saw their parent going through a tough time, and of course, they didn't know the intimate details of their medical treatment, but
Yeah.
in their mind they had it stuck that, oh, my mom and my dad was great until they went to the doctor that one time, and
Yeah.
then their health spiraled downhill and they ended up dying in a hospital. So
Mm.
we never know what the patient is dealing with or the patient has dealt with in the past that brings them to this present cantankerous state.
Yeah.
So I always try to hold space for that, for the why, because, one of the things that we learn in psychology is that, or at least we try to learn, or we try to tell people, is that very few people are intentionally bad or intentionally
I
evil.
mean,
Most
yeah.
people's actions are agnostic of intent. It's all about how we perceive the action or how we perceive someone's behavior that determines the value that we give to them. Because, if I see your behavior as bad, that's me. But someone around the corner, they may see you as a funny person. That may be the highlight of the day, that seeing that behavior. But I see this as abhorrent behavior. So it's all about my interpretation of your behavior that determines what I think you're doing. And if you don't think you're doing anything bad, then, of course, we're kind of at a disconnect. And the hope is that we kind of get on the same page about, what's really going on underneath, and we get to the why of your behavior.
That does take a lot of emotional maturity, though, I would say, on a physician's spot. Because for some physicians, that's already a ground to say, hey, she gets a letter.
Hmm.
It's like, yeah, I'm not seeing her again. Like, she gets a letter. That's for them, like I said, that could be an automatic firing offense. So as we round up, I'll just ask you one more. So for you,
Hmm.
what's a fireable offense for a patient?
A fireable offense. I've actually had a lot of patients who I would gladly fire. So, for me, a fireable offense is coming in with a certain agenda to manipulate me into doing certain things, especially if another physician took the time to explain to you why they weren't taking such an action, or they actually like gave you a good robust visit and you just weren't happy with it. So, and also how you treat my staff. It's one thing that if you have certain words for me, if you have certain behaviors towards me, because I can control my own reaction to how you're
Yeah.
being. I can't control how my staff takes your behavior and the effect it has on them. So I fired patients for coming in and yelling at the staff over prior authorizations for these GLP-1 injections.
Yeah.
One patient in particular earlier this year, he had to be fired. I wrote a prescription on, I think it was Thursday afternoon. I wrote the prescription, and I think Friday the pharmacy sent the cover my meds
Yeah.
office to get the paperwork started. And we tell all patients it could take 3 to 5 business days for this to be completed. I don't work on Mondays. So the very next day that we saw anything would have been Tuesday.
Tuesday.
Friday, he was in the office yelling at the front staff. And then Monday, he came to the office to yell at my staff about how long it was taking to do this prior authorization for a medication I had just written, like literally 2 days ago. So that's a fireable offense. There have been other patients who they saw other physicians in my practice and they didn't like the outcome of that visit. So then they would go up front and schedule an appointment with me. It's usually around these weight loss medications. There was another patient who she had a really high blood pressure and she wanted to be prescribed a stimulant for weight loss. The physician who's her primary care doctor said, no, you have high blood pressure and it's
Yeah.
uncontrolled. We can't prescribe this medication to you. So she scheduled an appointment with me, the new physician, and immediately she said, okay, I need this medication prescribed. I'm going on a trip. I need you to send it to this pharmacy. Like, just came in with demands,
Yeah.
not a hi, how are
Yeah.
you?
Yeah. Yeah.
Who
Yeah.
I am. This is just demands. And what I will do is I will go to their chart and I will look up the notes. A lot of my time is spent reading notes of other physicians because as soon as a patient comes in and tells me that this doctor such and such didn't tell them, didn't explain anything to them, didn't even give them the medication, I will go and I will pull up the note and I will read it to them and I will say, yeah, when you saw this physician, They said X, Y, Z to you. Do you remember that? Because they wrote in their note that they said these things to you, and this was their rationale. Their rationale is sound. I'm not going to go against their rationale because I agree with it. So you won't get this prescription from me either. And if they continue to push back, I say, well, we can head up front. We can cancel this visit. I'm good for canceling the visit because I'm not going to write a note for what
Yeah.
to do. So
Yeah.
cancel this visit, and you can go about your way because we're not in agreement here. If we can't agree on how the visit's going to go, by all means, you can choose another physician to see.
It's funny that you mentioned that, especially regarding the GLP-1s, that urgency. Because I mean, sometimes, I mean, out of it, it irks me just a little bit because I'm like, okay, you've been overweight for 10 years or obese, like a week
A
trying to
week
get this
later.
approved. Just be patient. It's a process because you're not even gonna lose the weight in the first week. But yeah, we do get that. It's like that medication needs to happen. Like, no, that's not always the way it works.
Mhm.
So thank you so much. It's been an awesome conversation. So if you were to leave one thing, like this is a doctor coming out of training and then trying to get into the system and trying to figure out like what's my practice as an independent doctor going to look like? Like, there's one advice that you would give them before they venture out on their own.
Mhm. Um, the advice I would give to any, like, I give to students, I give to any residents that come because I do rotations, and I tell them that um, this has become a profession more than a calling for a lot of people with the mandates that we have and all the work that we have to do. So I prioritize treating it as such. I don't lose sleep over medicine. I don't take medicine home. So if you want to start your own practice, you want to go out on your own, I would tell you to start getting into the habits that allow you to go home and be home because you don't get paid when you're at home. You get paid when you're at work. And one of the things that another one of the sayings I live by when I talk to my patients is I let them know that I care about their outcomes. I care about you, but I won't lose sleep over you. I won't, if you are not doing what you need to do, I will still sleep like a baby. Because when I was coming up in college, one of the songs by the what was the Young Bloods down here is that if you don't give a D, I don't give an F. So I'll tell them straight up, like if you don't care about what's going on with your health, I won't either. I'm going to explain to you what we need to do as a team to get your health going. If you show that, through your behavior or your inaction that it really is not important to you, I will also treat it as it's not important to me. So letting them know from early on because a lot of young docs they will get bogged down in what's going on with their patients. They'll lose sleep. They'll stay up for hours and hours obsessing over someone who is not even thinking about them at the moment. So it's important to care, but I would say that self-care is important because you can't pour from an empty cup.
Not
So
at the expense of yourself, pretty much is what you're
exactly.
saying. Yeah, yeah.
Yep. Not from the expense of yourself.
Awesome. Well, thank you so much for this conversation. I do know someone listening to would greatly benefit. I have learned a lot of things, especially with showing up for my patients. So you've been an awesome physician's keeper today, Dr. Roderick. And hopefully down the line, like I said, we're open to having many more conversations. If anything else you want to talk about from a physician standpoint. And so if you're listening and you enjoyed this conversation and you have a story as a physician, as a doctor, you have a story, you have an experience that would benefit another physician hearing it. We are open to those conversations. And if a student or someone wants to connect with you, Dr. Roderick, is there a way they can reach out to you or like just get some tips, if they're about to start practice, like
Mhm.
whether you be open to that? Okay.
Yeah, if you want to shoot me an email, my email address is rstewart at rkstewart.net. If you want to follow my professional Instagram page, I do a lot of actually do education on like sexual wellness. It's Dr. Rod Sex Educator, so Dr. underscore sex underscore meducator, Meducator. That's an
I'll
Instagram.
put those in the show notes. I'll put those in the show notes so folks can reach out to you. But thank you. Had an awesome time today. So hopefully we'll see you down the line in some other episodes.
Most definitely. Thank you for having me on. Have a good
Thank
day.
you.
Thank you for listening to Physicians Keepers. I hope today's conversation gave you something useful to carry into your life or practice. If it resonated, share it with another physician who might need it. And if you have a story that could help someone else, I'd love to hear from you. Connect with me on social media or send me an email. See you in the next episode.